Asmita, are we ready?
Yeah, you can start.
Good evening, one and all. I, Dr. Ganavi, on behalf of the Indian Thyroid Society, welcome you to another episode of the Wednesday Special Thyroid Clinics. So, we shall now start the session with the introduction about the Indian Thyroid Society. Indian Thyroid Society was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. Endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons are part of the Indian Thyroid Society. ITS is a member of the Asia Oceania Thyroid Association. It has currently nearly 2,000 members. In the executive committee, we have our founder, President Professor R.V. Jaikumar sir, and our current president, Dr. Shashank Joshi sir. Also in the executive committee, we have our past president, Professor Sarita Bajaj madam, secretary, Dr. Arun Menon sir, treasurer, Dr. Mini G ma'am. The vice president is Dr. Himagirish K. Rao sir, scientific committee coordinator is Dr. Pramila Kalra madam, joint secretary is Dr. Sujay Ghosh sir. Also in the executive committee, we have Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir, Dr. Mohammad Raya sir, Dr. Sushil Gupta sir. Also, Dr. Ashraf Chani sir, Dr. Mohan Shenoy sir, and Dr. Amaya Joshi sir are all members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals in order to promote the public education and awareness about thyroid disorders. The other aim is to encourage research in thyroidology and to encourage publication in the flagship journal, that is Thyroid Research and Practice. The state-of-art publications is also encouraged by the Indian Thyroid Society. Also, it awards fellowship as well as membership is also provided by the Indian Thyroid Society. So the ongoing academic activities by the Indian Thyroid Society include the CMEs, the updates, the symposia, and the conferences. The thyroid clinics initially were held weekly, fortnightly, and now being held monthly, have number of different topics like the journal club, the case conversation, the monologue, the duologue, panel discussion, meet the professor session, quiz, workshop, as well as CPCs. Also, the other programs which are observed by the Indian Thyroid Society include the Thyroid Awareness Week, which is between May 22nd to May 28th, the World Thyroid Day, which is celebrated on May 25th, and the Thyroid Awareness Month, which is usually observed annually in the month of January. So the research activities undertaken by the Indian Thyroid Society include the provision of annual grants for original research studies focused on thyroid and its related disorders, especially in the Indian context. Research grants are also available and it can be accessed through the website, that is indianthyroidsociety.in. So coming to the flagship journal, that is the Thyroid Research and Practice, it is published twice a year in print and online. It has a quick turnaround time with the electronic copies available ahead of print. So the fellowship by the Indian Thyroid Society is to be awarded to the ITS members who have expertise and experience in the field of thyroidology. It will be selected by an expert panel and the eligible members will be conferred the Fellow of Indian Thyroid Society. So the textbooks published by the Indian Thyroid Society include the ITS textbook of thyroid disorders. Editors are Professor Sarita Bajaj madam and Professor Rajesh Ratput sir. Also, the guidelines published by the Indian Thyroid Society include the Thyroid Disorders in Pregnancy Consensus Statement of the Indian Thyroid Society by Professor Rajesh Ratput sir, Professor Sarita Bajaj madam, Dr. Sujay Ghosh sir, Professor Pramila Kalra madam, Dr. Arun Menon sir, and Dr. Mini G ma'am. It is published in Thyroid Research and Practice in 2023. So the other upcoming guidelines include the management of subclinical hypothyroidism and the thyroid nodule as well. So the other guidelines published by the Indian Thyroid Society include the management of dyslipidemia and thyroid dysfunction, hypothyroidism and diabetes, management of depression and thyroid dysfunction. So Indian Thyroid Society can be accessed through the website, that is indianthyroidsociety.in, which has numerous contents like the links to guidelines, access to the ITS journal, records of all the academic events, as well as there is an online membership portal. So coming now to the membership, all MCI registered medical modern practitioners in India are eligible to become life members. There are two types of life membership. The amount is rupees 2,950. There is full-time life membership awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, and the associate life membership to all the other registered medical practitioners. So the membership is usually invited, the applications are usually invited online on the ITS website, which can be accessed through the link, that is indianthyroidsociety.in. So as we know, Indian Thyroid Society previously being headed by Professor Sarita Bajaj Madam and now being headed by Dr. Shashank Joshi Sir. And we have this thyroid clinics, which the main four conveners who are involved in conducting this thyroid clinics include Dr. Shashank Joshi Sir, who is the president, Dr. Pramila Kalra Madam, who is the scientific chair, Dr. Mini Ma'am, who is the treasurer, and Dr. Arun Menon Sir, who is the secretary. And in today's clinics, we have our distinguished chairperson, Dr. Professor P.K. Jabbar Sir, who will be chairing the session, and moderation will be by Dr. Felix Sir. We have two interesting case presentations with a quiz in between by Dr. Charandeep Sir. So without further delay, we shall start the session with the introduction of our esteemed chairperson, Professor P.K. Jabbar Sir.
Dummy quiz questions?
I think we have discussed that previously, but I think we can directly start since it's already 8:04. Dr. P.K. Jabbar Sir is presently the professor and head of the Department of Endocrinology, Government Medical College, Trivandrum. Sir has also been the director of Indian Institute of Diabetes, Trivandrum. Sir was also the executive council member of the Endocrine Society of India between 2020 to 2021. Sir is also the medical council inspector and a DNV assessor. Sir is also the principal investigator for several research projects and clinical trials. So with that, I hand over the session to Sir to introduce Dr. Felix and to start the session.
A warm good evening, my dear friends. First of all, on behalf of ITS, I think it's a very novel ideas put forward by our teachers. And ITS is doing a beautiful work and a commendable work because very active in academics, imparting knowledge, very active in research, very active in conducting other conferences also. This time, we have two important case discussions from Trivandrum Medical College. And for leading the discussion, we have a wonderful faculty, Dr. Felix. Dr. Felix is currently working in the caliber of Professor of Endocrinology, Department of Endocrine at CMC Vellore. And he is a notable personality in terms of his academics. He's a good orator and is a very active person in the association activities also. He's having good number of publications, index journals, around 72 international papers, and he achieved or he got gold medal in the examination also, and very active in academics even now. So with this brief introduction, I invite Dr. Felix to start the session. Probably after this session, I will introduce my another friend for conducting the quiz. Over to Dr. Felix, sir. Felix, sir.
Thank you, sir, for introducing and for the kind words. And so it's a pleasure to be here from as part of the ITS webinar, its special thyroid clinic session. And I'm sure this is going to be a session with more knowledge seeking for us, so that we will be able to provide much more empowerment to the viewers, so that they understand about the thyroid functions and the implications in the day-to-day practice. Because with the advent of immunoassays and the availability, we all know that thyroid functions have been done enormously across India than probably over the last 2 decades. So I now invite Dr. Archana, a senior resident from Trivandrum Medical College, to start her presentation, and we can discuss the further proceedings during the presentation. Over to Dr. Archana to take things forward.
Thank you, sir. Good evening, everyone. For first session of today's thyroid clinics, I'll be dealing with a few case scenarios which we have encountered in our OPD and created confusion with respect to the thyroid function test. So regarding the first case, patient was a 55-year-old male. He was a non-case of hypothyroidism diagnosed around 5 years back. He was on thyroxine 100 microgram daily, and there was no other comorbidities for the patient. And initially he had, as he was taking thyroxine of 100 microgram, he did not have any history of constipation, cold intolerance, dry skin or fatigue. And there was no history of swelling in front of neck. And he was not on any other medications other than thyroxine. And he was under regular follow-up from a local hospital. And during a review in the local hospital, he was found to have the TFT, which is described in the first table. His TSH was normal, T4 was normal, but the T3 level was found to be well above the upper limit of normal. That was 312 nanogram per deciliter, and the upper limit was 220. And in the local hospital, a physician advised him to stop the thyroxine tablet in view of elevated T3. And 1 month later, he presented with complaints of fatigue and constipation, and hence a TFT was repeated. And still, during that time also, the TSH was normal, T4 was normal, but T3 was elevated more than the previous value. That was 362 nanogram per deciliter. And during this point, patient was referred to endocrinology department of Medical College Trivandrum. And we saw him in our department. And during that time, he had complaints of facial puffiness, slurring of speech, fatigue and increased sleepiness, and also constipation, the symptoms which we encounter in hypothyroidism. And during that time, we took a detailed history, and he told that he was also taking pantoprazole and some vitamin tablets for GRD-like symptoms. And on examination, he was found to have a dry and coarse skin. His nails were normal. There was no goiter. His pulse rate was 70 per minute. Blood pressure was normal, and other system examination were within normal limits. And we advised him to stop all the medications, including pantoprazole and all the vitamin tablets. And we repeated a TFT after 1 week. And to our surprise, TSH was elevated. That was more than 100 microunits per ml. T3 and T4 were well below the normal lower limit of normal. It was very much reduced, including the free T4. Free T4 was 0.45 nanogram per deciliter. And we restarted him on thyroid. Yes, sir.
Can I interrupt here? I just want to know, is there any investigations was available prior starting the thyroxine weapon? That means the first visit TSH levels or T4 or free T4, anything was available in the historically was available with the patient?
Yes, sir. Initial presentation also, he had a similar TSH of more than 100, and T4 was below normal itself. And it was at that point he was started on thyroxine, and after 5 years only he has developed these complaints.
Okay, sure. Okay, thank you so much.
And he was restarted on thyroxine 100 microgram, and his symptoms got significantly improved after restarting thyroxine. And looking back into the case, the patient was already taking a vitamin tablet which contained a significant amount of biotin, And this could have been the result. This could have resulted in a lab interference in the immunoassay which has been performed for TSH and T3, T4. And hence, TSH was found to be falsely low. Because, even though the TSH was more than 100, it was found to be falsely low at a range of 2.3. And T3 was elevated. Despite a low value, it was elevated due to the biotin interference in the immunoassay.
Archana, I just want to clarify. Is there do you thought about prozone phenomenon when that, because the second TSH was around 2, because some assays still can have some degree of prozone phenomenon or kind of high dose hook effect. It's still possible in some of the
Yes, sir, it is possible, but the actually hook effect or prozone phenomenon usually affect the sandwich assays. And here the T3 was also found to be elevated, which is measured by a competitive assay. So when there is abnormality affecting two different assays, we thought about a biotin interference in this case.
Please go ahead.
Okay. So another case which is presented similarly. Patient is a 40-year-old male with no previous comorbidities, and he has presented to us with so many non-specific symptoms like body aches, and there was significant tremor for 1 year duration, but he did not give any history of palpitation, weight loss, or hyperdefecation to suggest a thyrotoxicosis. And he was referred with a deranged TFT to us, and only significant history was a family history of tremor in his mother. And on examination, his pulse rate was 80 per minute, was regular. He had coarse tremor predominantly of the hands. There was no goiter, and other systems were within normal limits. And this was the investigation which was done initially, that was done on a Roche base, and his TSH was 1.5, but the T4, T3, and free T4 levels were very well elevated above the upper limit of normal, but the TSH was normal despite an elevated T3, T4, and free T4. So we decided to repeat the test on another platform. So
did you think of any differential diagnosis by looking at this particular values of probably normal TSH with high T4 and high total T3?
Rare possibilities include it could be a TSH producing pituitary adenoma, where you can get a TSH which is normal or in the upper limit, along with a T4 and T3 which is elevated, and patient can manifest with symptoms of thyrotoxicosis. And another possibility is resistance to thyroid hormone. In that case also a similar picture can occur, but the symptoms will be different. Palpitation will be there, as there will be increased action of thyroid hormones on the TR alpha receptor. There could be tachycardia also, but that was not present in our patient.
Yeah, but your patient also is in the 4th decade of his life, 40 years, and slightly late. I mean, it's already is in the middle age. So
yes, sir.
probably.
Yes, sir. But patient did not have any typical symptoms of thyrotoxicosis, and usually TSH secreting adenomas will be larger. They will be macroadenomas, and they'll usually have symptoms of headache and raised ICT, and also visual field defects could also be present, but that was not present in our case.
Yeah, go ahead.
So we repeated the TFT in another platform, that was Siemens, and TSH, T4, free T4, and T3, all the investigations were found to be normal. And patient was referred to neurology department, and from there patient was started on propranolol after getting a diagnosis of benign essential tremor. And so the final diagnosis, it's a probable case of lab interference in the eclia by Roche, could be an interference in the biotin streptavidin interaction. Briefly regarding the biotin streptavidin interaction and how does it affect the sandwich and competitive assays when biotin is present in excess. Normally, TSH is a large molecule with multiple epitopes. So a sandwich assay is used for larger molecules like TSH, where you have two types of antibodies. One is a capture antibody, that is a biotin-related antibody, and another is a detection antibody, that is a signal antibody, or that has got a signal generating molecule attached to it. So normally when TSH is present in the serum, it will sandwich between the two antibodies, the biotin-related antibody and the signal antibody, like you can see in the right side of the image. And this biotin will get immobilized on the streptavidin binding sites on the magnet particle, and that will generate signal, and that is actually sensed in the assay. And in a sandwich immunoassay, the signal generated will be directly proportional to the TSH concentration, which means that if the signal is high, it is interpreted as a higher TSH level. But when biotin is present in excess, the sandwich that is formed between TSH and the two antibodies cannot bind to the streptavidin, as it will be already bound by the biotin which is present in excess in the serum, so that the signal generated will be falsely low. Though there is TSH in sufficient amount, the signal is not generated, as the sandwich cannot bind to the, or it cannot be immobilized, because biotin is already occupying the sites on streptavidin. So a falsely low signal generation occur, and it will be misinterpreted as a low TSH level, though the TSH is normal or elevated. So that is the mechanism of biotin interference in a sandwich immunoassay, where you get a falsely low result. But when you come to a competitive immunoassay, which we commonly use for smaller molecules like T3, T4, here it is based on the principle that here you have a T3 molecule that is present in the serum of the patient, and another T3 analog is there. This T3 analog and the T3 that we have added will compete for the signal antibody. Here there is only one signal antibody, and when the T3 is present, it will get bound to the signal antibody, and it will then attach to the streptavidin binding sites. And so that the T3, this T3 cannot be, the T3 analog is not detected. So in this case, the signal generated will be inversely proportional. Only if the signal antibody binds to the T3 analog that is attached to biotin, it will get it will bind to the streptavidin binding sites, and the signal is generated. But in the other case, when T3 binds to the signal antibody, the signal generated will be less, as it cannot bind to the streptavidin, as there is no biotin. So here it is the opposite to that. It is opposite to that of the sandwich assay. Here the signal generated will be inversely related to the concentration, which means that a higher signal generated means the concentration of the analyte will be low. But in this case, when there is excess biotin, the signal generated will be falsely found to be low, and that the analyte is falsely interpreted as a high level. So here the falsely high levels occur when you are using a competitive immunoassay in a patient with excess biotin. So that is how when you are using competitive immunoassay and sandwich immunoassay in a patient with excess biotin, you get a falsely low level of TSH and falsely elevated level of T3 and T4. Sir, can I go on to the second case?
Yeah. So just want to ask you, do you think that this could be a familial dysalbinemic thyroid problem, or a hyperthyroxemia in this case? Do you think that, is it a possibility by any chance?
Yes, sir. Here in this patient, there was no family history, and the patient was asymptomatic. In both these cases, the patient did not have, patients were not having symptoms. So the one point in favor is that patient did not have any symptoms, and the TSH was found to be normal. T3, T4 was found to be elevated. Even the free T4 can also be elevated in cases of familial in certain assays. So that could be a possibility, but as there was no family history, we ruled out it as a possibility, sir.
Sure. Yeah, there are some questions. I think we can discuss this question a little later.
Okay.
Jabar sir, would you like to comment on the discussion, sir?
Dr. Felix, you can proceed, because I know the case and say I'm also
Okay.
involved in the workup. Okay, please proceed.
Sure.
Okay.
Thank you so much, sir.
Sir, I'll move on to the next case scenario.
Yeah, sure. Please go ahead.
Okay, sir.
If there is any doubt, I'll just raise my hand. I won't interrupt you. So if I raise my hand, you can always stop, and then I can answer. So
Okay,
I won't interrupt you. Okay, thank you.
Patient is a 44-year-old male. She is a non-case of hypothyroidism for 5 years. She was on thyroxine 150 microgram, and she was asymptomatic at presentation to us. And she was referred for elevated TSH while on thyroxine. That was the reason why she was referred to endocrinology department. She did not give any history of drug default, and the drug was properly stored, and it was adequately spaced from food, and she was not on any other drugs which is known to interfere with the absorption of thyroxine. And on examination, there was no goiter, skin and nails were normal, pulse rate was 90 per minute, blood pressure was normal, and other systems were within normal limits. And her lab investigation showed an elevated TSH of more than 100 with a normal T3, T4 and free T4 level. And we increased the, yes, sir.
Because you mentioned in your history that there is no history to suggest that any other drug which can probably alter the absorption of thyroxine. That's what you mentioned in your history. So what do you exactly, because it would be good to have discuss that, what are the drugs you thought about it, which probably could reduce the absorption of thyroxine?
Yes, sir. I have thought about iron calcium tablets, which can bind to thyroxine and inhibit the absorption, and other drug, which is PPI, proton pump inhibitor, which can alter the gastric pH and thereby inhibit thyroxine absorption. And other drugs like cholestyramine, cholesevelam can also inhibit the absorption of thyroxine from the GIT.
Yeah, it's very common to actually, especially in women who are pregnant women, they have been prescribed iron, calcium supplements, and on top of thyroxine. It's many times patient confused and takes everything in a bulk. If you are not being educated about the taking medication, and other thing is very common to take ranitidine and pantoprazole or omeprazole over the counter. Many times we don't prescribe for some of the illnesses of any other problems, but they do go to the over the counter and take it without our knowledge. So that has to be taken care of. So if suppose the patient asks you saying that I want to take pantoprazole for a long time, well, what would be your advice in such patients?
Sir, if iron calcium, we can give a gap of around 4 hours after taking the tablet. You can ask the patient to take it after 4 hours.
Is there anything you think that pantoprazoles or omeprazoles we can probably tell the patients? Because many patients is take in the morning, but
at bedtime, patient can be asked to take the tablet at bedtime, sir.
Yeah, either that one or it's as simple as the patient gives, you can take it in the afternoon, or maybe you can say that after a gap of 1.5 to 2 hours, they can take it.
Okay.
That is one, or the ideal would be to best is to give in the afternoon so that there won't be any interference at all.
Okay.
So that the acid comes back to normal by the time in the morning. If you give in the night also, then many times you have a gap of 8 hours sometimes. So, but ideally you can go up to 90 minutes to 2 hours. But I would suggest that probably take it in the noon time, where even the bulk of the meal is in the lunch time, especially the long-acting PPIs.
Okay. So we also advise the patient to take the tablets regularly, and also we ensured an adequate spacing from food. And we reviewed her after 6 weeks. And during that time, she presented with complaints of tremor, palpitation, and hyperdefecation. And she lost around 2 kg weight in a month, and she was not on any other drugs. On examination, she had fine tremor, and there was tachycardia, which was regular. JVP was not elevated, and chest was clear. And we repeated the test in 2 different platforms. The TSH was astonishingly found to be on the higher side of more than 100, but T3, T4, and free T4 levels were also elevated, more than the upper limit of normal. And considering the symptoms, we reduced the dose to 150 microgram per day, and she symptomatically improved. And we planned for further evaluation, but she didn't turn up. So this could probably, first DD we kept was non-compliance, but in this case, as patient developed symptoms of thyrotoxicosis due to excessive thyroxine, that was ruled out. Other possibilities are interference due to macro TSH or a heterophile antibody, which can falsely elevate the TSH levels, which I'll show in the next 2 slides. So this is macro TSH. So normal TSH weight is around 28 kilodalton, and macro TSH is actually a larger TSH molecule, which is bound to immunoglobulin. It has got a molecular weight of around 150 kilodalton, and it is not biologically active, but it can interfere in the assays. It can bind to the antibodies in the immunoassays used, and it can give rise to a falsely elevated TSH level when you are measuring in a patient having macro TSH in her blood. So that is how TSH can be falsely elevated in a patient having macro TSH. And another thing is heterophile antibody. So heterophile antibodies are directed against their anti-Ig antibodies. So when there is no interference, this is how a sandwich assay works. The antigen is bound to both the capture antibody and the detection antibody, and the signal is generated, which is sensed by the assay. But when a heterophile antibody is present, it can sandwich between the capture antibody and detection antibody, even in the absence of the antigen. So the assay will be interpreted as a falsely high value of the analyte. And this is the most common interference that can occur with a heterophile antibody. And rarely it can also block the antigen from the capture antibody and result in a falsely low value. But usual cases are falsely high value due to sandwiching between the two antibodies used in the sandwich immunoassays. So these are the mechanism by which macro TSH and heterophile antibody can falsely elevate the TSH. Sir, that's all about the cases.
Okay, sure. Yeah. Last patient, if you want to do any test to confirm that this is not absorption related, can you do any test which can probably suggest that could be an absorption problem?
So we can go for a levothyroxine absorption test, where you ask the patient to come fasting, and we'll administer a prefixed amount of thyroxine to the tablet, usually 600 microgram. There are different values in different papers. And then we'll measure hourly the free T4 and T4 or the T4 level every hour for around 5 hours. And we can look on the increase in the free T4 levels.
Any increment which could be probably suggestive that there is no or rules out absorption?
So percentages are there, sir. 60% is one which was suggested in a recent paper in JCM. It was 60%, more than 60% increase in free T4 can be considered to be normal absorption. And if it is below that, you have to search for other GI causes or liver diseases which can impair the absorption of thyroxine.
Yeah, that's true. There are a lot of values which suggest that 80, 40%, 50, 60, but by and large, the traditional teaching is around up to at least 50% increase in the thyroxine levels is considered to be probably rules out absorption problem.
Yes, sir.
Do you think any other cause could be there? Can you show us the TSH results? And so this is after, even in spite of doing in a different assays, right?
Yes, sir.
Do you think that this still could be a central hyperthyroidism causing a big, large macroadenoma sitting inside and causing all this? By looking at the assay alone, looking at the results alone?
The TSH is not usually this much elevated in a TSH secreting adenoma. Usually it is normal or just above the norm.
Many times it's normal or just high normal or maybe a slightly high, maybe because it's not a common disease to occur. Yes. And more so if it is occur, then it generally don't go beyond 15 or 20 million international units or micro international units per ml. Yes, it will be subtle, but though the size of the tumor is aggressive and with a lobulated nature with supracellular, it's a massive tumor with a lot of compressive symptoms, but by and large, they don't cause this much of high TSH level. So currently, what is the patient is on 150 micrograms, isn't it?
Yes, sir. Yes, sir.
So have you able to do the absorption test on this patient?
No, sir. She was actually, we were planning for further tests to look for macro TSH also, but she was lost to follow up. So
okay, fine. So you don't have a definitive evidence to suggest what exactly could be the reason behind that thing. So that's I think for the benefit of further discussion, there are some few interesting questions across the board. So probably we can discuss that and have a discussion further. Janavi, do we have time to discuss this question, or we'll go to the next case or quiz and then take these questions back because it's 8:31.
Yes, sir. We have time. We have time till 8:40, sir.
Okay, so we can
So-
probably discuss these questions
Yes,
and then probably because there are some 7 questions, the relevant questions,
Yes, sir.
the interesting questions on semaglutide and etc. Because it's been a talk of the town in many of the conferences. And so first question was if I'm not mistaken, it's AKT means they are talking about anti-tubercular drug, which can cause hypothyroidism. Archana, would you like to answer any anti-tubercular drug which could cause hypothyroidism?
Sir,
I believe
rifampicin can inhibit the binding of thyroxine to the thyroid binding protein, thyroxine binding proteins, and it can falsely elevate the FT4 levels.
yeah, so drugs like etionamide, basically etionamide is nothing but an thionamide group of drug. Basically, it's an etionamide which is used in the drug-resistant tuberculosis. So that it's nothing but anti-thyroid drug. So it can cause, and also PAS used to give a very bulk doses.
Okay.
So that can also cause some degree of hypothyroidism. And certain retroviral drugs also has been shown to have some effect on having an effect on hypothyroidism. But by and large, I think AKT, what they mentioned is probably they asked the question is that one. So the second question is if it was due to biotin, why T4 was normal and T3 was elevated? I think you explained this already in your talk that if I'm not mistaken.
Sir, TSH was actually elevated more than 100, but it was falsely low as 2.3. It was affecting both TSH as well as T3 assays.
Yeah. So I think that also has been answered. So I think the third question is, I think it's how do you interpret TSH, free T3, free T4, TPO antibodies? I think you can answer this with how the negative feedback mechanism causes high TSH and low T3 and T4 levels. Probably you can explain it for the viewers.
So normally T3 and T4 exerts negative feedback at the level of hypothalamus, that is TRH and TSH. So when there is an increase in the free T3 and free T4 levels, it can inhibit the TRH and TSH. So when it is above the upper limit, you can get a suppressed TSH level. But when in the reverse, like when the free T3, free T4 levels are on the lower side, that is mainly the primary part. If it is affecting the thyroid, then it can falsely elevate the TSH level because the feedback is not working properly due to the low hormones. It can increase the TSH as well as the TRH levels because of the loss of feedback inhibition at the level of hypothalamus and pituitary.
Yeah, I think just to add on what Archana said, many times the TRH actually also causes prolactin elevation. So many times if you ask a battery of test of all the hormones, even sometimes with a severely hypothyroidism, they can actually have an elevated prolactin, which look like prolactinoma and many times, but may not be that high, like a risperidone-induced hyperprolactinemia. But so need to be really careful because very severe hypothyroidism, which high TRH can actually cause prolactin elevation also, and shouldn't mix up many times and have a wrong diagnosis. I think thanks for the discussion. There is another question. Would you like to talk about semaglutide and levothyroxine? Because when you was talking about the thyroxine interference about food and the medication, I think nowadays semaglutide has been prescribed quite a bit and it's been considered. So would you like to talk about it a little?
Sorry, you can advise the patient to take semaglutide in the morning and thyroxine at the night bedtime if you're taking sema.
Wait, can you repeat it again?
Sir,
sorry, I didn't hear.
Sir, if the patient is on oral semaglutide, we can ask the patient to take the thyroxine tablets at bedtime after the meals, about 2 hours after the meal at night.
But this is interest. There are quite a bit of studies which has actually a contradictory information on this, exactly the thyroxine and semaglutide, which basically the studies are contradicting, but by and large, semaglutide you give around 30 minutes before breakfast, and thyroxine probably after 90 minutes. They mention it is not much of a problem, but it's got a lot of contradictory information still coming out, especially in the online forums. But definitely we need some more study to really, actually, I would suggest to say that how really the semaglutide function. But one of the things they suggest is you can take bedtime and probably give a time gap, and so that it can prevent it. But probably still I would think a little different. Probably I would suggest to, if you really have a doubt it, give the semaglutide pre-lunch. Why we want to give it really in the morning and make it complicated?
Okay.
Jabbar sir, would you like to comment on the cases, sir? Or
No, I think say Archana did a beautiful work and very meticulously investigated the patient and the patient parameters. You all know that. I think nothing more to add. And regarding the this thing, amiodarone, someone was asking about amiodarone hypothyroidism. Amiodarone definitely theoretically that can produce hypothyroidism. That's true. But we are, as a physician, we are not much bothered about hypothyroidism. We are much bothered about or thyrotoxicosis. It's very easy to manage hypothyroidism due to amiodarone, but it's very difficult to manage thyrotoxicosis if patient develops thyrotoxicosis. As you all aware, there are two types of thyrotoxicosis due to amiodarone. Both this situation difficult to differentiate also. Only subtle points by which you can differentiate. But if the patient develops problem, that will be a problem for a clinician. I think that's all for this case. I think Ganabi will accept that. The time is up. Right, Dr. Ganabi?
yes, sir.
Yes, sir. All right, sir. Yes, sir. So thank you, Dr. Felix, sir, and Dr. Archana for a wonderful, insightful case discussion. So moving on, we have a quiz coming up by Dr. Charandeep, sir. So I now request Dr. Jabbar, sir, to give a brief introduction about Dr. Charandeep, sir.
I wanted to congratulate Dr. Ganabi for arranging this beautiful flow of events. And now you can relax, and those who are interested in quiz program, you can participate in quiz program. Basically, this quiz program is conducted by our own friend. He is Dr. Singh. He is currently working as a consultant endocrinologist at Patiala, and is a person keenly interested in high-tech medicine or technological medicine like pump treatment, CGMS, and of course, other areas of endocrinology, including gestational diabetes mellitus, growth hormone treatment, and very interesting and emerging topic that is transgender. Is a very astute clinician and a good orator, and is having a lot of publication, especially in technology-related topics in diabetes. Over to Singh for conducting the proceedings. Singh, sir. Dr. Singh is online.
Yes, sir. I can see him as one of the panelists.
Yeah.
Hello, sir.
Yes, I think Dr. Singh is here.
Am I audible to you, sir?
Yeah.
Yeah, but you are not
Please
visible,
proceed, sir.
sir. Hello.
Hello.
You are audible, but you are not visible to us.
Okay, let me see.
Yeah.
So till then, Asmita, shall I give a brief introduction about the quiz participation rules?
Yes. Now you are visible, sir.
Hello, good evening, everyone. Hello, good evening, sir. Thanks for the kind words, sir.
So I'll just give a brief introduction about the quiz participation rules before we proceed.
Please proceed.
device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All the 10 questions will be available when the poll is lodged, and the answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So, Asmita, shall we have the dummy questions?
So in which, yeah.
Yes, sir. Yeah.
So in which city is Taj Mahal? Option A, Chennai. Option B, Mumbai, Agra, and Bangalore. Question second, how many oceans are there? Option A, 8. Option B, 5. Option C, 6. Option D, 7.
Sir, you can share the screen for actual quiz.
Hopefully the screen is visible to everyone.
Yes, sir, it's visible. You just read out the questions.
So question
and-
1.
Yes.
Let me see. So thyrotoxicosis, especially in postmenopausal women, leads to bone loss and increased fracture risk. Which of the following statements regarding the thyroid hormone action on skeletal system is correct? Option A, duration of bone remodeling cycle is reduced in thyrotoxicosis. Option B, hydroxyproline and C-terminal telopeptides are elevated while osteocalcin goes down in thyrotoxicosis. Option C, thyrotoxicosis leads to elevated 125-dihydroxy vitamin D3, which ultimately contributes to hypercalcemia and Graves' disease. Option D, TSH stimulates bone remodeling by acting through the extrathyroidal TSH receptor on osteoblasts and osteoclasts.
So you can move to the second question.
So second question, in 2015, a multidisciplinary panel introduced the terminology NIFTP neoplasm for a variant of papillary thyroid cancer. Which of the following statements is correct about NIFTP? Option A, papillary architecture is one major diagnostic criteria. Option B, NIFTP predominantly harbor RAS mutation. Option C, FNAC provides definitive diagnosis in suspected cases of NIFTP. Option D, NIFTP is known for its high mitotic rate.
You can proceed for the third question.
So third question, several tyrosine kinase inhibitors have received approval in recent years for treatment of advanced medullary thyroid carcinoma. Which of the following statement is true regarding the use of TKIs in MTC? Option A, vandatinib and cabozantinib are KDR-VEGFR2 sparing RET inhibitors. Option B, vandatinib and cabozantinib are cytotoxic to MTC. Option C, cabozantinib can be used safely in patients with a QTC prolongation. Option D, vandatinib is more potent but causes more severe adverse effects compared to cabozantinib. So question number 4, alemtuzumab is monoclonal antibody targeting CD52 and commonly results in thyroid dysfunction. Which statement is incorrect regarding the thyroid dysfunction in patients taking alemtuzumab? Option A, most common thyroid dysfunction is Graves' disease. Option B, only patients of multiple sclerosis on alemtuzumab has been reported for thyroid dysfunction. Option C, family history of autoimmune disease is a risk factor for thyroid dysfunction. Option D, direct cytotoxicity is the commonest cause of thyroid dysfunction in patients with alemtuzumab. Question number 5, which of the following statements is incorrect regarding the IgG4 thyroiditis? Option A, serum IgG4 of more than 135 milligram per deciliter or high plasma IgG4 to IgG ratio provides definitive diagnosis in the case of thyroiditis. Option B, number of IgG4 plus plasma cells are inversely proportional to the disease duration. Option C, IgG4 thyroiditis is more prevalent in males. Option D, compared to Riedl's thyroiditis, IgG4 thyroiditis causes rapid thyroid failure. Question number 6, teprotumumab has emerged as a promising medicine in moderate to severe Graves' or orbitopathy patients. It highlights the importance of TSH receptor and IGF-1 receptor crosstalk in pathogenesis of orbitopathy. Choose the correct statement about teprotumumab out of the following. Option A, like IV glucocorticoids, teprotumumab improves disease activity but not the disease severity. Option B, teprotumumab blocks TSH IGF-1 receptor crosstalk by displacing TSH receptor antibody from the extracellular domain. Option C, teprotumumab causes hyperglycemia in approximately 37% of patients. Option D, teprotumumab causes internalization and degradation of IGF-1 receptors. Question number 7. A 26-year-old male presented with a long-standing history of thyrotoxic symptoms with a similar history in his father. On examination, he had found grade 1 goiter. His investigations revealed free T3 of 6 picogram per ml, free T4 of 3.6 nanogram per deciliter, and TSH of 2.8 milli-units, international units per liter. Which of the following tests is not helpful in differentiating the resistant to thyroid hormone from TSH adenoma? Option A, levothyroxine suppression test. Option B, TSH response to TRH. Option C, depot somatostatin response. And option D, levels of SHBG, sex hormone binding globulin. So 32-year-old pregnant woman with a history of radioiodine ablation presented to an endocrinologist. Currently, she is 14 weeks pregnant, getting levothyroxine 112 micrograms. Her TRAB antibodies were at the time 4 times upper than the upper limit of normal. Which of the following statement is not true for the management of her case, considering the risk of placental transfer of TRAB? Option A, immediate fetal ultrasonography should be done to look for fetal heart rate and other signs of fetal thyrotoxicosis. Option B, presence of distal femoral ossification center before 31 weeks point towards the accelerated bone maturation in such cases. Continuing levothyroxine along with methimazole is a good strategy once the fetal thyrotoxicosis is confirmed. Option D, self-limiting neonatal thyrotoxicosis can last up to 3 months, after which treatment generally can be discontinued. Question number 9. A 48-year-old female presented with a neck discomfort without any compressive symptoms. She was concerned about the neck disfigurement. Clinical examination and investigation revealed non-toxic multinodular goiter. Ultrasound revealed multiple nodules with the largest nodule of 1 centimeter TR2 lesion. After discussion about management options, she opted for radioiodine as she wanted to avoid surgery. Which one of the following statement is false about radioiodine ablation in her case? Use of recombinant human TSH produces 50% more goiter reduction compared with the radioiodine without RH-TSH. Option B, thyroid volume reduction by radioiodine is of the same magnitude in toxic and non-toxic multinodular goiter. Option C, recombinant human TSH use results in lower incidence of the hypothyroidism. Option D, use of radioiodine in non-toxic multinodular goiter can lead to Graves' disease and ophthalmopathy. So the last question, 32-year-old male of Graves' disease presented with Graves' orbitopathy. He noticed visual blurring for the past 24 hours. On evaluation, CS score was 5 out of 7 on left and 3 out of 7 on the right eye. And fundoscopy did not reveal any papilledema, but perimetry showed central scotoma on left side. T1 weighted images on MRI revealed apical crowding bilaterally left more than right with 3 mm proptosis. Which of the following statement is incorrect in this case? IV glucocorticoid is superior and preferred first-line therapy compared to surgical decompression. Option B, rituximab is a good choice if patient has already received 8 grams of IV glucocorticoid. Option C, dysthyroid optic neuropathy due to nerve stretching responds poorly to IV glucocorticoids. Option D, orbital radiotherapy combined with IV glucocorticoid can reduce the recurrence of dysthyroid optic neuropathy. With this, we have finished the total number of 10 questions.
Thank you, sir, for a very challenging quiz. The answers for the main quiz that is conducted today and also these are questions which were displayed yesterday will be discussed at the end of the session by Dr. Charandeep, sir. So now I request Dr. Felix, sir, to introduce our next presenter, Dr. Ashwin. So I think we can, Asmita, can you please display the...
Thank you, Dr. Charandeep Singh, for the wonderful quiz, and thanks, Ganavi, for leading the session, and thanks, Dabasar, as well, be with us all through. So next presenter is also a resident from Department of Endocrinology, Government Medical College, Trivandrum. This is Dr. Ashwin. Dr. Ashwin, could you please take over the session and lead us with your case presentation?
Yes, sir.
Sir, can you keep
Am I
your
quite visible, sir?
laptop camera near to your face? Camera near to the face. Yeah.
Can I start, sir?
Yes, let's
Good evening, all. So our patient was a 73-year-old female from Kollam, Kerala. She presented to us with history of weight loss for the past 2 years. She had around 30 kilogram of weight loss over the past 2 years, and which was associated with the loss of appetite. She also had constipation and abdominal pain for the past 1 year. She had a diffuse abdominal pain, however, there was no vomiting or abdominal distension. And she also reported to have palpitations for the past 6 months, and which was present even at rest, and also noticed that there was tremors over the hand. So in view of her abdominal symptoms, an USG abdomen was taken from a local hospital, and she was detected to have an ovarian mass, and she was admitted in our gynecology department for staging laparotomy for an ovarian mass. And during a preoperative evaluation, she was detected to have hyperthyroidism, and she was referred to endocrinology for fitness for procedure. So when we took the history, there was no history such of heat intolerance, hyperdefecation, or increased sweating. No history of any chest pain, exertional dyspnea, orthopnea, swelling of legs to suggest any cardiac involvement. No history of vomiting, yellowish discoloration of eyes to suggest hepatic involvement. No history of bone pain, fractures, or muscle weakness. There's no history of any swelling in front of neck, and no history of fever, neck pain, sore throat to suggest thyroiditis. And also the past history, there was no history of diabetes mellitus, hypertension, and she has never been admitted to hospital in previously. And there was no history of any malignancy in family. Her diet was a non-vegetarian diet, sleep was reduced, bowel and bladder habits were within normal, and there was no addiction. Now, coming to the examination, she had pallor, her BMI was 20.8, there was no goiter palpable. She had fine tremors over her hands, warm, moist hands, but there was no signs of Graves' dermopathy, orbitopathy, or acropathy. There was no vitiligo or hyperpigmentation. Vitals were stable. System examination, CVS and respiratory system was within normal limits. There was no hepatosplenomegaly, but a mass was palpable in the suprapubic area. The lower border could not be made out. So basically, she was admitted in gynecology in view of an ovarian tumor, and the possibility of ovarian malignancy was considered. Now she is also having thyrotoxicosis in view of 6 months duration of palpitation and tremor. Our first possibility kept was Graves' disease. We also consider the possibility of subacute thyroiditis. Now, as she was planned for surgery, her initial T4 level was 21.6, T3 was on the higher range, and TSH was suppressed. Free T4 was also elevated. She was started on carbimazole at a dose of 20 mg per day, and along with propranolol 40 mg. Yes, sir.
Dr. Ashwin, can you just recollect how long the duration of the thyrotoxic symptom was?
Thyrotoxic symptom was like palpitations and tremors was present for the 6 months, but she was having this weight loss and abdominal symptoms for around 2 years. Sir.
Okay, suppose if the patient say that I have the symptom for last 2 weeks,
yes,
and then patient is having an ovarian tumor.
yes.
What could you be thinking? They might have had an imaging done and come to you probably 3 weeks back and say that symptoms have started after doing the imaging.
Short duration of symptoms, we have to suspect thyroiditis first, sir. 2 weeks duration.
What do you think about iodine-induced contrast-related thyroiditis? A shorter duration of that?
Yeah. It can also present as in the short period, sir.
Yeah, because many times that's because they do a contrast in CT somewhere outside and not in the center where you are sitting, and many times it get because the patient, they may not reveal that, and they won't bring the film, or they come with one small paper with says a diagnosis alone, maybe ovarian tumor sitting there. So it's a very common phenomenon to see a iodine contrast because it's freely available. The contrast studies are not uncommon these days.
Yes.
Yeah, thank you.
Okay.
Please go.
Okay. So she was started on carbimazole and propranolol dose of 40 BD. This was a routine investigation. She had anemia, HB was 9.9, ESR was on the higher side, that is 87, and ECG showed a sinus tachycardia. And all tumor markers workup was done from the gynecology department. Beta HCG, LDH, AFP, and CA125 was also normal, within the normal range. So our basic aim was to prepare her for surgery. So we had increased her dose of carbimazole, and also as she was planned for an immediate surgery, we added polystyramine and also Dexona to decrease the free hormone levels so as to make her euthyroid prior to surgery. And the T4 almost came in the normal range, and free T4 also came in the normal range. So our diagnosis initially was thyrotoxicosis, probably primary hyperthyroidism, and to rule out Graves' disease was our initial impression. So a USG neck was done, which was suggestive of a very small nodule was there. And as we are suspecting Graves' disease, we proceeded with a technetium uptake scan. And this was a technetium image, and there was no uptake in the neck. So it was a negative uptake in the technetium scan.
So what do you think all the causes? Suppose the patient comes to you with technetium scan alone, or maybe an I131 scan. If they have center can probably procure I131.
Yes.
So if there is absent or reduced uptake, so what are the things probably we might need to discuss in this patient?
An absent uptake in the neck can be due to different causes. The most important cause is subacute thyroiditis, and also acute pyogenic thyroiditis can have a negative uptake, and other forms of thyroiditis like silent thyroiditis. Then substances interference due to iodine containing substances is a common cause for negative uptake even when the patient is having Graves, when the patient is having hyperthyroidism. Then also we can get a negative uptake also in other conditions like struma ovary, which is a rare condition, and also metastatic follicular thyroid carcinoma. We can have a negative uptake scan with hyperthyroidism features.
No, why I asked this is because the patient had ovarian tumor.
Sure.
I'm not very sure whether the patient had a iodinated contrast study, and the technetium scan was done afterwards.
Yes,
So whether
yes.
it's a
No, sir,
false.
only, yes, sir. She underwent only USG initially, and also an MRI abdomen was done. If she underwent a CT abdomen, we should at least wait for 3 months to proceed with the technetium check, is what the guideline is.
Yeah, that's what I want to just to clarify the doubt. Yeah, sure. Please go on.
So meanwhile, an MRI was also done, which was suggestive of a large lesion, a lesion of size 12 centimeter. Now in this scenario, we have thyrotoxicosis with a negative uptake in technetium scan, and we are having a ovarian mass. So as we have already discussed, the negative uptake in technetium scan, one possibility is struma ovary. So with an ovarian mass, we suspected the possibility of struma ovary. So she was given fitness to undergo staging laparotomy with total abdominal hysterectomy, and after explaining the risk of thyroid storm, and she was taken over to OBG for operative management. So then she underwent staging laparotomy. This was the image, intraoperative image. You can see a large lesion of size 10 centimeter, 16 into 10 centimeter with solid and cystic areas. And this was the gross appearance. And this was a histopathology. As you can see, there are thyroid follicles as we suspected. This is a case of struma ovary. And also another interesting finding which we got was there was also a coexisting Brunner tumor. Now this is imaging of the Brunner tumor. We can see fibrostroma. So this is a combination of Brunner tumor, which is an epithelial tumor, and also a struma ovary, so germ cell tumor. So this is a very rare combination to see. And there were no features of malignancy per se. The struma ovary, the thyroid pattern was of benign nature. After the surgery, this was her pattern of TFT, that is the T4 and 3T4 levels came to normal range, and she was euthyroid. So our final diagnosis was hyperthyroidism due to struma ovary. This is non-malignant. Yes, sir.
Just in one of the very interesting case, but just want to add on one, which one of my professor used to say, Dr. Sheshadri, whenever you have a old lady comes to you with a suspicion of thyrotoxicosis, and if you feel there is the uptake is negative, and ask the nuclear medicine physician to do a camera of the abdomen. He used to tell us. So, though it is a very rare, he used to tell us that that probably can mention early diagnosis. So I was just thinking of that.
Yes, sir. For diagnosis here also, SPECT-CT would be optimum to see an uptake in the pelvis region. But as she was planned for surgery and already we did a technetium uptake, we were not able to proceed with the SPECT-CT. She was not willing, so we were not able to proceed with the SPECT-CT to show a uptake in the pelvis. But it was later proven with histopathology that it was struma ovary, and she had good clinical response also.
Yeah, sure. Please, and I thought just share the thing which we were. One of my professors used to tell us, old lady with a mass palpable, if you feel thyroid and thyroiditis or thyrotoxicosis, just ask the nuclear medicine physician to shift the gamma camera to down and take a photograph.
Since it is a rare case, I will briefly go through the review of literature. So it is a variant of dermoid in which the thyroid constitutes more than 50% of the component. So the thyroid tissue should involve more than 50% to tell it as a struma ovary, and it is usually found in a woman with the age group of 40 and 60 years. It is usually benign, as in our case, with the malignant transformation in just 5%. But if the transformation is malignant, the prognosis is usually bad. And it constitutes 3% of ovarian teratoma and also 0.5% of all ovarian tumors. It is usually non-functional. Only 5 to 15% can present with hyperthyroidism. And this is one of the largest series of struma ovary, and in the case of 34 patients, but none had presented with thyrotoxicosis. And tumor markers, CA125, there is little clinical value in struma ovary. It can be elevated both in benign and malignant conditions. In our patient, CA125 was normal. Thyroglobulin may be elevated in both benign and malignant cases. It can be used as a follow-up as a marker to response to treatment, especially in case of malignancy and metastasis. Now, as Sir have already mentioned, the optimum way to identify pre-op was a SPECT-CT, where we can get an uptake, thyroid uptake in the pelvis region. So, and USG will be suggestive of a cystic ovarian mass with solid components of various amounts, and the characteristic struma pearl will be visible in the ultrasound. And MRI abdomen, as mentioned, can have a cystic solid area. Treatment is usually anti-thyroid. Prior to surgery, we have to restore the patient to euthyroidism. Benign struma ovary, only surgical resection and oophorectomy with salpingectomy is needed, and we can follow up the patient. However, if it is a malignant struma ovary, we have to consider radioiodine ablation, and whole body radioiodine scan and thyroglobulin can be used for follow-up. And there are case reports of collision tumors, like a strumal carcinoid has been reported, where there is presence of both carcinoid and thyroid tissue within the struma ovary. And in our cases, there is coexistence of Brenner tumor and struma ovary. So why we presented this case is that, one, hyperthyroidism as a presenting feature of struma ovary is very rare, and a collision tumor, that is a coexistence of a Brenner tumor with struma ovary, is very rarely reported in literature. Thank you.
So, have you planned to publish this case?
Yes, sir. Plan.
I think that's the way to go, because it's the rarity of the tumor, and not very, very uncommon to have hyperthyroidism as a presenting as a tumor ovary. And very good. That's a very complete evaluation and therapy, and finally you got a definitive diagnosis for that. Is the patient still on follow-up, or?
Yeah, she was on follow-up, sir. Last month also she was on follow-up. She's now euthyroid.
She's euthyroid, and so have you done any thyroglobulin after the? I understand this is a benign tumor,
yes,
but
yes.
any thyroglobulin is available just for follow-up?
The pathology department, sir. Since it is a benign, we thought we'll follow up the patient. We have not done a thyroglobulin.
Gotcha. Okay, fine. I think what's the plan?
Yes, sir. So we will conclude this the case presentation, sir, with your permission.
I thought the quiz has to be discussed, so that's why.
Yes, sir. Yes, sir. Yes, sir. So the case presentation we shall conclude, sir. Is it okay?
Yeah.
Next, we shall have the quiz answer discussion, sir. So I thank Dr. Felix, sir, and Dr. Ashwin for a very captivating discussion. So moving on, I now request Dr. Charandeep, sir, to discuss the answer for both the set of quiz questions that was conducted yesterday as well as today. So over to Dr. Charandeep, sir, to discuss the quiz questions and also to announce the winners at the end.
So I'm going to discuss the main quiz, these 10 questions that I have asked. So the first question was thyrotoxicosis, especially in postmenopausal women, leads to bone loss and increased fracture risk. Which of the following statements regarding the thyroid hormone action on skeletal system is incorrect? So the correct answer is duration of the bone remodeling cycle is reduced in thyrotoxicosis. As we know, thyrotoxicosis results in a high bone turnover. Frequency of initiation of bone remodeling sites is increased, but the duration of the bone remodeling cycle is reduced. So the net effect is that the overall bone remodeling cycle is reduced, but out of the bone remodeling cycle, the bone formation is reduced to a higher extent compared to the bone resorption. So that results in a net 10% loss of bone per remodeling cycle. So the answer was A. Duration of bone remodeling cycle is reduced in thyrotoxicosis. So the next.
So we are not able to see the slides, sir.
Okay. Are you able to see them?
Yes.
Yeah, now
yes,
we
sir.
can see. First question
Okay.
is visible. Yeah.
So the first, the answer was duration of bone remodeling cycle is reduced in thyrotoxicosis. This was the correct answer here. So the second question was in 2015, a multidisciplinary panel introduced the term NIFTP neoplasm for a variant of papillary thyroid carcinoma. Which of the following statement is correct about the NIFTP? So NIFTP is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So here it typically harbors the RAS mutation, and this cannot be reliably diagnosed preoperatively. So the entire capsule must need to be reviewed by a pathologist to make a diagnosis of NIFTP. And the tumors which has no penetration of capsule, blood vessels or lymphatic vessels, only that tumor can be labeled as a case of NIFTP. So FNAC cannot be used, cannot provide the definitive diagnosis here. And NIFTP is known for its a low mitotic rate rather than a high mitotic rate. So papillary architecture, as the option A, papillary architecture is one of the major diagnostic criteria. Actually, it is not a major diagnostic criteria. Rather, it's the nuclear features has to be there of papillary carcinoma, not the papillary architecture. The papillary architecture should contribute less than 1% of the total tissue. So the option was B. So the third question was several tyrosine kinase inhibitors have received approval in recent years for treatment of advanced medullary thyroid carcinoma. Which of the following statement is true regarding the TKIs in MTC? So the correct answer was cabozantinib can be used safely in patients with the QTC prolongation. So as we know that vandetanib, but not cabozantinib, can result in prolonged QTC. But cabozantinib can be used here. And the newer generation TKIs, which is selpercatinib as well as the pralsetinib, they are more specific they are more specific RET inhibitors, and they spare KDR-VEGFR2 receptors. But these vandetanib and cabozantinib, they are the first generation. They inhibit the KDR-VEGFR2 receptors also. So this is one of the reasons they have a less specific and more side effects compared to the newer generation TKIs. So then the question for alemtuzumab is a monoclonal antibody targeting CD52 and commonly result in thyroid dysfunction. Which of the following statement is incorrect regarding the thyroid dysfunction in patient taking alemtuzumab? So the correct answer is here. Direct cytotoxicity is the commonest cause of thyroid dysfunction in patient with alemtuzumab. Actually, alemtuzumab is commonly used in patients of multiple sclerosis, rheumatoid arthritis, and leukemia. And in one study, it has been shown that around 33% of patients of alemtuzumab treated for multiple sclerosis patients, they have thyroid dysfunction. And out of those 34% patients, roughly 6% had Graves' disease. So the most common thyroid dysfunction on alemtuzumab is Graves' disease. And de novo development of the thyroid antibodies has been seen in such patients. So direct cytotoxicity is not the commonest cause of thyroid dysfunction in patients with alemtuzumab. So the next question was, which of the following statement is incorrect regarding the IgG4 thyroiditis? So the correct option here was serum IgG4 more than 135 milligram per deciliter or high plasma IgG4 to IgG ratio provide definitive diagnosis in case of thyroiditis. So basically, IgG4 thyroiditis is characterized by intense lymphoplasmacytic infiltration and dense fibrosis and follicular degeneration. This obviously leads to a very rapid thyroid failure compared to a person of Friedreich's thyroiditis. To make a definitive diagnosis of this condition, you need to have a combination of clinical, immunological, and histopathological criteria. Isolated serum elevation can just suggest you the diagnosis, but for making a definitive diagnosis, you need a combination of both immunological as a histopathological criteria. And it is more common in males, and number of IgG4 plus plasma cells, they are inversely proportional to the disease duration. That is, after once the disease is in the burnt out phase, IgG4 level, IgG4 positive plasma cell goes down. So the next question was, teprotumumab has emerged as a promising medicine for moderate to severe Graves' orbitopathy. It highlights the importance of TSH receptor IGF-1 receptor crosstalk in pathogenesis of orbitopathy. Choose the correct statement for teprotumumab out of following. So the correct answer was teprotumumab causes internalization and degradation of IGF-1 receptors. As we know that teprotumumab is a fully human IgG1 antibodies that blocks the IGF-1 receptor. And it leads to a near complete internalization and degradation of IGF-1 receptors. In one of the studies, hyperglycemia has been seen in around 10 to 12% of patients versus 5% in placebo. So it is not seen in more than 1/3 of patients. It is around 10 to 12% only. And apart from that, around 4 millimeter of reduction of proptosis was also seen in patients who were on teprotumumab group. So teprotumumab also not only it decreases the disease activity, but it also acts on the disease severity also. So number 7, a 26-year-old male presented with long-standing thyrotoxic symptoms with similar history of his father. On examination, he had formed grade 1 goiter. His investigations revealed high T3, T4 levels with the relatively normal TSH level, which one of the following tests is not helpful in differentiating the resistant to thyroid hormone from TSH adenoma. So in literature, classically, it is the LT3 or levothyroxine suppression test, which is used rather than the levothyroxine suppression test, because it has a direct effect on the tissue, bypassing the potential defects in the T4 transport and the metabolism. So this can lead to variable reports, variable responses if you use T4 as a suppressive therapy rather than the levothyroxine. So apart from that, there is a more rapid onset and offset of T3 action also helps to reduce the period which is required to complete the test. That's why levothyroxine suppression test is recommended, not levothyroxine. The rest of the responses like TSH response to TRH, depot somatostatin response, as well as SHBG levels, they are used. They have been mentioned in the literature to differentiate between the two entities. Then question number 8, 32-year-old pregnant woman with a history of radioiodine ablation 2 years back visited an endocrinologist. Currently, she is 14 weeks pregnant with and getting levothyroxine 112. Her TRAB antibodies are 4 times higher than the upper limit of normal. Which of the following statement is not true for management of her case considering risk of placental transfer of TRAB? So the correct answer is immediate fetal ultrasonography should be done to look for fetal heart rate and other signs of fetal thyrotoxicosis. So as we know that the fetal, So as we know that the fetal hypothyroidism can complicate around 1% of women with either active or treated cases of Graves' disease. And the maternal, but the maternal IgG, they cross placenta after 20 weeks of gestation by the help of micropinocytosis with IgG binding to the Fc receptors of the syncytiotropoblast. So at 14 weeks, there is no chance of even the TRAB antibodies traveling to the fetus, as well as the thyroid gland has not developed to cause a fetal hyperthyroidism. So at that point of time, doing ultrasound to looking for heart rate is not going to help in such cases. Only in the early part of this, only in the mid gestation, we can perform a fetal ultrasonography, or at that time we should look for the fetal for the signs of fetal thyrotoxicosis, not before that. So the question 9, a 48-year-old female with neck discomfort without any compressive symptoms. She was concerned about the neck disfigurement. Clinical examination revealed non-toxic multinodular goiter. After discussion about the management options, she opted for radioiodine as she wanted to avoid surgery. Which one of the following statements is false about the radioiodine ablation in non-toxic multinodular goiter? So here the correct answer is recombinant human TSH use results in a lower incidence of hypothyroidism. So apart from curing the hyperthyroidism, radioiodine can reduce the volume of goiter. Thyroid volume reduction of approximately 40% at 1 year and 50 to 60% at 2 years is reported in both toxic as well as non-toxic multinodular goiter. So the main drawback of recombinant human TSH use is that it increases the uptake of radioiodine, and therefore they tend to have a higher frequency of hypothyroidism is seen in such cases. But it helps to enhance the goiter volume reduction. So commonly it is used, but the chances of getting hypothyroid is also increased in such cases. So then coming to the last question, 32-year-old male of Graves' disease presented the Graves' orbitopathy. He noticed visual blurring for the past 24 hours on evaluation of CAS 5/7 on the left and the 3/7 on the right side. Fundoscopy did not reveal papilledema, but perimetry shows central scotoma. So which of the following statements was incorrect in this case? So the option B was the answer. So rituximab is a good choice in patient who has already received 8 grams of IV glucocorticoid. See, in various RCTs, there are two main RCTs. One is Italian study and another is US study. Many of the patients has been shown to develop deterioration of proptosis and visual loss, and even frank dysthyroid optic neuropathy develop once they are given rituximab. So one of the hypotheses for this is that this can cause a massive lysis of the intraorbital lymphocytes, and which can cause cytokine release syndrome in such cases with the edema as well as expansion of the orbital tissue. This can lead to progression of the subclinical dysthyroid optic neuropathy, because here the patient was already having an impending with visual blurring and 5 out of 7 score, and MRI was also showing crowding. So he was already having signs of dysthyroid optic neuropathy happening. So in such cases, giving rituximab can actually cause a deterioration. So in case IVGC is an option, it should be given. Otherwise, rituximab should be avoided in such cases. Thank you.
Sir, is it possible for you to discuss the teaser question answers as well?
Unfortunately, I'm not having that on slides. Can I read it here? The answers I can tell you.
Yes, sir. Yes, sir.
Okay. So in teaser questions, the question, those were the factual questions. So the first question was, which of the following is not associated with increased TPG concentration? So the option A was methadone, option B was nicotinic acid, option C was 5-fluorouracil, and option D was raloxifene. So the correct answer was answer B. Nicotinic acid is not associated with the increased TBG concentration. So the second question was, which of the following biochemical defects they are expected to be present in case of Allen-Heddon-Dudley syndrome? Option A was low T3 to T4 ratio, high reverse T3, low SHBG, high lactate. So the answer was D, high lactate. So high lactate is expected to be present in a case of Allen-Heddon-Dudley syndrome. So the third question was, which of the following defects has been shown to respond better with the levothyroxine replacement rather than the levothyroxine replacement? So the option A was SECISB2 BP2 mutation, MCT8 mutation was option B, RTH alpha mutation was option C, and option D was Pendring mutation. So the correct answer was SECISBP2 mutation. A was the correct answer. Then question number 4, there was a growing concern about the role of endocrine disruptor in thyroid dysfunction, and bisphenol is one such chemical. What is the likely mechanism for thyroid disruption in bisphenol A? Option A was activate uridyl diphosphate gluconyl transferase. Option B was inhibit thyroperoxidase. Option C was inhibit sodium iodine transporter. Option D was it inhibits the thyroid hormone receptor. So the correct answer was D, that bisphenol A inhibits the thyroid hormone receptor. So the option was D. So the last question of teaser quiz was, by means of selective permeability, placenta plays an important role in development of fetal thyroid axis. Which of the following molecules have least permeability across the placenta? So question A, so the option A was iodides, option B was thyroid autoantibodies, option C was T4, and the option D was PRH. So according to the permeabilities, option C, actually T4 has the least permeability compared to the rest of the molecule as per given in the deep root. So option C, T4 was the correct answer.
Thank you, sir, for discussing the answers. I now request you to announce the winners, the most awaited part. So announcement of the quiz winners.
So our winners is Dr. Malhar Sheth, Dr. Varun Mahatre, and Dr. Prachi Gite. Congratulations to the winners. Quiz winners on 9th August, Dr. Neelam Yadav, Dr. Lakshmi S, and Dr. Abhijit Javanjal for 9th August quiz winners. Congratulations to all the winners.
Thank you, sir. We shall now we have now come to the end of the session. I request Dr. Pramila ma'am to give the concluding remarks.
Yeah, thanks, Dr. Ganvi. And it was really a nice discussion today. Thanks, Dr. Jabbar sir, for excellently chairing the session and always be a mentor. And thanks, Dr. Felix. It was excellent moderation done by you. And the two residents who did an excellent job with the two difficult cases, Dr. Ashwin and Dr. Archana. And Dr. Charandeep, the quiz was really mind-boggling today. So that was really nice. So that I think the residents also enjoy the quiz. This is one of the things which all the residents look forward to. So not to forget Dr. Ganvi, she is always there, who is running the show seamlessly. So thanks, Dr. Ganvi, as well. And thanks our IT team. Dr. Sarita Bajaj ma'am could not join today because of some prior engagements. And we also are thankful to Dr. Shashank Joshi, who is our president of Indian Thyroid Society. And I think we look forward to the next session, which Dr. Ganvi will be just telling, we are putting the brochure, right? So we'll be having that. And also one request to everyone who have joined today, that if you have any articles which you want to send, Thyroid Research and Practice is the journal of the Indian Thyroid Society. And please send your articles if you have any case reports, full text, any review articles, please send. it will be peer reviewed, and if found suitable, will be published in the journal. So any articles, please send, because it's a journal of our Indian Thyroid Society. So it's a request to everyone to send your articles to the TRP journal, and the website is open. You can upload it online only. So Dr. Ganvi, I hand it back to you, and you can take forward from here.
Yes, I thank Dr. Jabbar sir again for chairing the session, Dr. Felix sir for moderation with insightful discussion, Dr. Charandeep sir for a very challenging quiz, Dr. Archana and Ashwin for their explicit presentation. So for the next session of Thyroid Clinics, that is on 13th of September, we have Dr. S.V. Madhu sir chairing the session. Dr. Deepthi Sharma ma'am will be moderating the session. There'll be 2 case presentations with the quiz in between by Dr. Sanjeet Jaiswal. So with that, we also have upcoming thyroid clinics on the following dates. So Asmita, can we have the dates for the next thyroid clinics as well? So after September, on 11th of October, followed by 8th of November and 6th of December will be the thyroid clinics. So I request everyone who's attended today's thyroid clinics to actively participate in the following thyroid clinics as well. So with that, we conclude. Thank you and good night, everyone.
Thank you. Good night, everyone.
Everyone, and good night.